Happy Monday, everyone, and welcome to our webinar, How Analytics Can Help in the Next Phase of COVID-19. Our panelists today are Laura McCrary, President and CEO of Kansa. Kansa provides health information exchange solutions to health plans, health systems, providers, public health, and much more. Kansa also connects to other health information exchanges and to the National eHealth Exchange. Laura is here to speak to us today about how her organization is helping with information sharing in this next phase of the COVID-19 pandemic. George Deely is Vice President of Healthcare Solutions at Dimensional Insight, the 2020 Best in Class Healthcare Business Intelligence and Analytics platform. He will share with us how Dimensional Insight is helping its customers better understand their data to help in areas such as lost revenue and what some of the lessons learned from the pandemic are. And I am Kathy Susich, Director of Healthcare Marketing at Dimensional Insight. I will be moderating today's discussion. Here's a quick look at our agenda and some of the areas that we'll be covering today. If you have any questions today, please type them in the questions box in your GoToWebinar panel. We will hopefully have time for a few questions at the end. In addition, we will be giving away a $100 Amazon gift card or donation to Direct Relief at the end of the webinar. You must be present to win, so please be sure to stick around for that. Let's start off by talking to Laura about the issue of data sharing and contact tracing. So Laura, it seems that we are over our big hump of infections here in the US, though there are several states that are seeing an increase in confirmed cases and hospitalizations over the last several weeks as states has started to reopen. Contact tracing is important as we try to prevent further spread of the virus. Laura, what is your organization doing to help public health officials have accurate information on COVID patients for contact tracing?
Thanks, Kathy. I appreciate the opportunity to spend a little bit of time with you today. As Kathy indicated, Kansa is a health information exchange. So we receive real-time data from all of our participants, and we have about 130 hospitals or so that provide us with real-time ADT data feeds. An ADT data feed, for those of you who aren't familiar with that, is a data feed that comes directly out of your electronic medical record system, and it includes information on patients that you see there at the hospital. And ADT stands for admit, discharge, and transfer. So what we know right away is basic demographic information about the patient who's been at the hospital. So we'll know, for example, their name, their address, their race, their ethnicity. We'll also know when they were admitted into the hospital, if they were transferred in the hospital, if they were discharged. And then depending upon the ADT feed, we'll also know what is the patient's admitting diagnosis, what's their discharge diagnosis, who were the doctors that actually provided care to the patient in the hospital. We'll also know what unit or location they are in your hospital. So there's a lot of information that comes into a health information exchange that then allows us to aggregate all of that data. We use a Dimensional Insight data visualization tool to be able to put this data in a very nice sort of dashboard view for our State Department of Health and Environment. And then they use that data that we provide to them for contact tracing. So what I wanted to do here is show you kind of the basic information that's coming across to us. And so we have a patient account number. The easiest way for you to think about that, if you're familiar with it, is just like a medical record number. But we assign a unique patient account number to each patient, and then any records that come in associated with that individual patient, we hook those together so that we can see the longitudinal view of that patient. And so you can see, what is the message timestamp? So when did we actually send that message to the State Department of Education? And then that big blue box, this is actually real patient data. So we've just blocked that out, for purposes of HIPAA protections. But you can see across the top there, it says patient first name, last name, date of birth, and gender. And then you can also see patient ethnicity and race. And I know for most of you as healthcare professionals, you realize that race and ethnicity have become very important as we're looking at the spread of COVID and those patients that are most susceptible to the virus. So we also know what was the date of admit. And so you can see here, this is a fairly recent screenshot from 5/29, so from May 29th. And then you can also see date of discharge. If you don't see a discharge there, then what that tells you is the patient's still in the hospital. And then it'll tell you what kind of type the patient is, whether it's outpatient or emergency or inpatient. And then the unit there, it actually is telling the State Department of Health whether or not the patient has been admitted into intensive care. And so the State Department can see exactly where the patient is in your hospital, depending upon the unit. And then if we get a discharge disposition, a lot of times electronic medical record systems will not send a discharge disposition, but sometimes they will. So we'll know that the patient's been discharged to home, or they've been discharged to skilled nursing facility, or they've been discharged to a rehab facility. And so, Kathy, let's switch to the next slide, please. So what you can also see, this is sort of just imagine these two slides are put together in one long view. So you can see over there on the left-hand side, discharge disposition again. But then you can see that they're sending facility. So this is now going to be the name of whatever the facility is that we've received the data from, along with the information that's necessary for contact tracing. So what's the patient's phone number? What's their address? Where do they live at? What county in our state are they in? What's the zip code? And then you'll see there what was the actual diagnosis. And if you look up at the top, really right above the blue box and just a little bit to the right, you'll see code. And what we're looking for there are the different diagnosis codes that come across in the ADT feed. So if the State Department is just looking for those patients that have confirmed diagnosis codes, they would choose the U07.1. You guys have all become as familiar with these diagnosis codes for a positive COVID diagnosis. And so the U07.1 is a positive COVID diagnosis. And generally what that means is that they do have a confirmed lab result that indicates that the patient does have COVID. But then you'll also see if there is suspected exposure. And so if you actually are doing contact tracing, you're going to want to know if there's also suspected exposure. And so there's actually a new code that's been added since this particular screenshot was taken. But one of the things that's really nice about the Dimensional Insight tool is that we can quickly add in or eliminate pieces of information that the State Department no longer is finding necessary or has determined that they would like to see. For example, one of the things they've now asked for is for us to start sending in all of the lab tests as well. It was a little bit difficult early on to determine what was going to be most helpful for people around contact tracing, because there was some question about, well, should you wait for the confirmed diagnosis or should you go ahead and start trying to do contact tracing when you've got a suspected exposure? So now what we really are going to start adding in here is that the lab has been completed, right? We've actually completed the lab test, but it has not come back yet with an actual confirmed diagnosis of COVID. So they'll know that there's been a suspected exposure. They'll also know that there's been a lab test that's been completed and that we're waiting for the results. Now, we are starting to see in our state some of the rapid lab test results. We've got some labs now that are being able to produce results in about 15 minutes. So that's really very helpful. But all of this is then what's necessary for our State Department to actually be able to manage and be able to see in near real time what's happening across our state. So we found it interesting to see how the State Department used this data, because as you know, particularly if you're from a hospital, you know that you have 4 hours from the time you've got a positive COVID result back to contact the State Department to let them know you've got a positive COVID test back. So, you know, I think what we felt early on is that was really being the hospitals were really adhering to that 4-hour time frame, They were actually getting the calls made into our State Department and manually entering that information into the portal. But what's happened is that, now that we're 4 months in, just regular workflow issues have sort of gotten in the way, and it's sometimes that timeline of 4 hours is not being sort of kept up to date. And so what we find the State Department doing is looking at what was manually entered by the hospital staff, and then what does the data that we've received out of their electronic medical record system actually tell them about the number of COVID positive patients that they have at the hospital, or patients that are suspected and they're awaiting lab tests. So it's one of the pieces of information that we've found is that they're using this to sort of double check in terms of the hospital reporting, just to make sure that they've got the most accurate and up-to-date results. So that's what's been happening at the hospitals, and I'll talk a little bit more about it if we have time, and I'm certainly willing to answer questions at the end about how this is put together. But Kathy, let's switch to the next slide as well. So one of the, go ahead.
I was just going to say, Laura, alerting is very important for physicians, so they know when their COVID patients have been in the hospital. And I know it's also becoming increasingly important for the hospitals themselves. So can you talk about that a little bit?
Yeah, thanks. I didn't mean to talk over you. So Kathy's exactly right. So it is important for the State Department of Health to know about COVID patients in the state, but what's also really important is for physician practices and hospitals themselves to know that a patient's either been diagnosed with COVID or has had a suspected exposure. So we provide a dashboard to our physician practices and to our hospitals that alerts them. The primary alert is to say, you've got a patient that's been admitted to a hospital. And so some of you are familiar with these alerting products. They're pretty common now across the nation. And some of you know that you're going to, as a hospital, you're going to have to start providing alerting out to physician practices and primary care practices and post-acute care facilities. So this is a product that we use to provide that alerting to our hospitals. So what happens here is, because we have these data feeds that are coming into us near real time from the hospitals, we're watching that data feed for a practice or for a hospital's patients. And we define a practice or hospital's patient as any patient who's received care at that practice or at that hospital in the last 18 months. So if the patient's been in your hospital, we define that in the last 18 months, then that patient belongs to you. They may belong to other places as well that they've gotten care in the last 18 months, but they belong to you. And so if that patient goes to any other hospital, we're going to alert you through this dashboard and say, hey, your patient has just shown up at the hospital, 3 hours away because they were in a car accident, going out to the Rocky Mountains to go skiing, or your patient's just shown up at the hospital across the street. So that's really what this is designed to do, is to provide the alerting to the hospital or to the physician practice. So if you're a primary care doctor, you know immediately that your patient's been admitted into the hospital, either into inpatient or into emergency. And then in addition to that, you can see the big red tab there will also tell you which of those patients have a positive diagnosis of COVID. And so that's really nice to know if you're a physician practice, because in many cases, even here in our state in Kansas, we've had some situations where patients have had to be transferred from what we would have considered sort of a normal community hospital to a hospital that had the ability to actually have a COVID unit. And so a lot of times the patient might not, be admitting into their community hospital. They might actually be transferred, to a larger trauma hospital that has a COVID unit. So the physicians are being notified in near real time that their patients have been admitted into the hospital, whether it's into ED or into the emergency, and the hospitals are being notified as well. And so what this also does is it helps our hospitals meet this new alerting requirement that all hospitals have to meet by May 1st of 2021. in order to be able to continue to maintain your conditions of participation with Medicare and Medicaid. So we've really used the Dimensional Insight tool in a couple of different ways here, but all of it's really around being able to use analytics and really use the data that comes in to a health information exchange in order to provide better, more accurate, and certainly more timely information to our doctors and hospitals. So with that, Kathy, I'll turn it back to you.
Great, thank you, Laura. And one thing that we've learned from COVID is that people with comorbidities have worse outcomes. So this means that understanding population health is even more important moving forward. Laura, what is your organization doing on that front?
Well, thanks, Kathy. We provide a lot of information back out to our practices and hospitals in dashboards. And we have, I think I mentioned, we have about 130 hospitals that send us data, but we also have about 2,500 other organizations, whether they're physician practices or public health departments or mental health facilities, pharmacies, labs that send us data as well. And so we aggregate all of this data into a clinical data warehouse, and then we have a variety of different dashboard products and tools that make all the data from the health information exchange into information that's actionable and usable for our doctors and hospitals that participate with this. So what this particular dashboard is doing, it's called our disease registry dashboard. It's really helping a practice or a hospital really understand where their patients are that have specific chronic disease conditions. So down at the bottom, you'll see zip codes with highest patient population. And so in this particular dashboard, you can choose between different chronic disease conditions, and then you can look and see who are the patients that have that disease condition, who are the patients that might live in a specific zip code, so that you might be able to target particular initiatives in that zip code that might help out a large number of patients, say with, for example, diabetes. Might be a good place to target actually having a variety of exercise or nutrition-based facilities. So the goal really is to use the data that comes into the health information exchange and be able to aggregate it together to provide meaningful information. So if you look at the top right-hand corner, you can see sort of the gender and age by disease registry condition. And so you'll be able to see what the age is for those patients and what the gender is, and you'll be able to actually look at really a pretty specific breakdown. If you clicked actually and drilled down, as you know the Dimensional Insight product does, if you click on any of these, you drill down into the actual patient name, address, and information. So this is a pretty nice tool. Our practices, our hospitals in particular like this when they're doing their community assessments and they're being able to look at market share related to particular disease conditions. Why don't you switch to the next slide? And this is just another one that is kind of gives you information that's specific by facility as well as by disease condition. So you can see high-risk patient lists up at the top, ED visits, payer breakdown. So there's lots of good information in here that is specific to a particular facility. So you can see, for example, a hospital like Via Christi Hospital, what their chronic disease condition breakdown is. And you can see, if you actually drill down in here, so this is for your practice. Remember, this is your practice. You can see which hospitals your patients are going to, what are your disease conditions, how many emergency room visits have your patients had, how many emergency room visits have your patients had that have more than 5 disease conditions. So it's a pretty comprehensive way to look at your data. Thanks, Kathy.
Great, thank you, Laura. Now we're going to talk to George Deely from Dimensional Insight about some of the financial impact and what hospitals can do with analytics to help understand that impact. George, one of the things we've been talking to customers about is the concept of lost opportunity. What do we mean by that?
Hi, Kathy. So yes, to look at that in context, it's one of the many facets of the financial impact of the pandemic, which include increased costs associated with personal protective equipment, medical equipment like ventilators, the additional staffing for treating patients with coronavirus, including those on standby, the cost of building out facilities, testing, which in some states has been quite extensive. And there's the cost of caring for coronavirus patients. Length of stay has tended to be longer than a typical case mix. So the existing standard reimbursement policies don't work particularly well. And then finally, there's lost opportunity that's come from the suspension of elective care, such as surgeries and diagnostic procedures, plus routine preventative care. And that suspension was mandatory and the impact's been very significant, but there's also been somewhat unintended effects. Fewer people have come to hospitals for urgent and emergency care. ED volumes have been down considerably in areas affected by the coronavirus, which has led to lower volumes for inpatient and observation care that would have resulted from those ED visits. But those units have continued to be staffed, so there are costs associated with that for which there was little return.
And George, what about on the reimbursement side?
So there have been several sources of relief funding, including the CARES Act and the Payroll Protection Program, which provides relief funding for PPE, staffing, the coronavirus testing, and then the cost of caring for COVID-19 patients, plus the lost opportunity. There's been disaster relief through FEMA. CMS has provided advanced payments for Medicare population and also premium payments for caring for COVID patients, given the additional costs. But by most accounts, this is really just scratching the surface of covering the actual costs. Our state hospital association here in Massachusetts tells us that hospitals are continuing to compile data, but it's pretty clear that the losses above and beyond the reimbursement will be pretty considerable. So more relief may be on the way, such as the Health Act that's currently being debated in Congress, but it's unlikely it will be able to make up for what's been lost.
So George, where do data and analytics come into play to help us manage through this?
Well, there's a few ways and possibilities. First, understanding the impact for purposes of both applying for and providing documentation for relief funding. The terms and conditions of the CARES Act funding, for example, require quarterly reporting and attestation beginning in July. Now, I've yet to hear from anyone on the specifics of what's required, but the consensus seems to be that the reporting requirements won't be overly daunting, but time will tell. That can always change. Next, there's managing the process of restarting normal operations as the restrictions are lifted. And there'll be a considerable backlog of elective and preventative care. And that's one area where our customers have asked for our help, leveraging the data that they already have to determine the best approach for doing that. And the challenges are several-fold. For example, optimizing the utilization of facilities and equipment for surgical and diagnostic procedures. For example, health systems are working to more flexibly and dynamically allocate surgical scheduling blocks to take advantage of capacity as much as possible to work through the backlog. Physician practices are generating prioritized patient lists to help providers reach out to patients to evaluate needs and reschedule appointments where physical appointments are possible, or to provide virtual alternatives, phone calls or video visits. And many practices and service lines have solidly booked schedules, so making up for 3 months of canceled and postponed visits will take time. So prioritizing the more urgent appointments is a necessary part of the process and very much data-driven.
Thanks, George. Now, during and after any crisis, it's always worth examining and seeing what lessons can be learned so you can improve for next time. What are some of the lessons or best practices that have emerged as a result of the pandemic?
Yeah, so the amount of information that's been generated during the course of the pandemic from around the world is really astounding. Data from countries that were affected early on, like China, South Korea, Italy, and Spain, have provided guidance for countries like the US and South American countries that have come later. And the universal accessibility to data has also been an advantage. So anyone can go to the Johns Hopkins or several other COVID-19 websites to see daily updates on COVID-19 measures compiled from around the world, in some cases down to a granularity of a zip code. So with that information, states and countries have been able to take a very quantitative, evidence-driven approach to both managing the crisis as well as reopening. In Massachusetts, for example, we have 3- and 7-day trends on infection rates, hospitalizations, and deaths that have been used as guideposts for the reopening process. And analyzing this information at the population level, such as by zip code, demographic breakout, or ethnicity, has identified disparities in both the vulnerability to infection as well as access to care. So there's definitely opportunities to apply a more population health oriented approach in the future, as Laura alluded to.
And George, how can the experience with COVID-19 help to guide the response to similar situations in the future?
Well, it's pretty clear that from the COVID-19 pandemic that shutting down everything completely is very challenging and probably not a sustainable strategy. We wouldn't be able to do this again next year. The financial impact on hospitals and health systems that run on small margins in a lot of cases to begin with is devastating. And the care that wasn't provided as a result of limiting access has more than likely had its own adverse outcomes. For example, how many people didn't seek emergency care for early signs of stroke or heart attack, and what was the result? Probably not good. We'll no doubt need a different approach the next time around, but it's the experience and the data from the COVID-19 pandemic that can help in formulating strategies to run normal operations in parallel with a disaster response while still protecting the health and safety of both patients and providers.
Now let's take a look at the technology impact. How has COVID-19 changed the role of technology in healthcare?
So one thing that's very clear is that telehealth or virtual care is here to stay. Healthcare leaders have consistently shared that initiatives such as virtual care that they've been working and planning on for years came together in a matter of weeks when the need to operate differently forced that change, and the health system by and large has risen to that occasion. One surprise that I've heard consistently from healthcare leaders has been the overwhelming acceptance of virtual care by both patients and providers, even though it's been implemented quite rapidly. Early survey results through Press Ganey, for example, indicate that patient satisfaction scores improved significantly when virtual visits became the norm. And patient engagement technology has also shown promise in creating a more effective and ongoing interactive dialogue between patients and their care providers. Everything from surveys to reminders to opportunities to share perceptions of care and outcomes are contributing to an important new source of information. Individuals and caregivers and actually staying engaged in their health in a much more active way. I had my first virtual visit, a physical, last week, and it was an interesting experience, but it was on time, went quickly, and ended on time.
So George, what role will data and analysis play in all of this?
So there will likely be much more of it as a result of increased monitoring and these new electronic channels and a focus on global disease surveillance. We've seen how important it is to spread that information, disseminate that information quickly to get out ahead of a potential pandemic. And the continuing improvements to machine learning techniques and AI will help to assimilate that information and make sense of it as it becomes available. There's really no way to do it without that technology. There's also plenty of room for innovation in how information can be best conveyed to consumers of that information. For example, visualization has played an important role in helping the public to understand the importance of strategies such as social distancing and flattening the curve, really helping them to kind of get a handle on what the impact of doing or not doing certain things is across the population. And It's also apparent in the race to find treatments and vaccines against COVID-19. The clinical trials process is being accelerated due in part to the ability to collect, process, and interpret information in real time, and then change course quickly as necessary.
Great, thank you, George. Now we're going to get to some questions in just a minute. So now is the time to type in a question for our presenters if you have one. And we will have our gift card giveaway following the Q&A. While you're doing that, let me take a minute to tell you a bit about Dimensional Insight. We help our customers keep complex problems simple with our industry-leading analytics platform, Diver Platform. We are a 7-time best-in-class winner for healthcare business intelligence and analytics. We have expertise in both analytics and in healthcare. We work with our customers and partners to help them innovate quickly. And if you'd like to talk to one of our experts, please reach us via phone, email, or our website, all listed here. You can also find us on social media. So be sure to follow us for regular updates on healthcare analytics. Okay, we have time for just a couple of questions. Our first question, George, how can technology aid in improving our response to the next crisis?
So the countries in Asia who were affected by the SARS virus a few years ago were able to pull out that playbook as a starting point for their response to COVID-19. And technology tools like contact tracing were available very early in their response, and that seems to have had a positive effect. Since COVID-19 was even more widespread than SARS, there'll be opportunities to learn from the various approaches from around the world to determine the best course for the future. But transforming the knowledge and experience that came out of the COVID-19 experience and the strategies for responding to future events represents a big opportunity for technology, some of which we can't even envision yet. But one thing's for certain, there's data and analysis will play a huge role.
Our next question, what information has been most important and impactful during the pandemic?
Yeah, that's something that'll probably be better understood in time. I mean, one thing's clear, it takes a lot of time and energy to both collect and interpret the information, and more isn't necessarily better. The experience in Massachusetts has been that the amount of information that needed to be reported by hospitals actually decreased over time as it became more apparent what really mattered. So continually refining what information is useful, and being willing to adapt was an important lesson learned. Sharing information through a variety of electronic forms, including video, like the webinar that we're doing right now, really contributed to disseminating lessons learned in U.S. hospitals in Washington. In the U.S. Hospitals in Washington State, for example, were able to pass along what they had learned as they got hit early in the process to other states so that they could incorporate that experience into their own responses. And I think that's made a huge difference, and probably will continue to make a difference as the virus doesn't seem like it's over quite yet, unfortunately.
And our next question is for Laura. Laura, do you do any predictive modeling on any of the data that you shared?
That's a great question. And we do have some predictive modeling, not a lot. It's one of the areas that we're moving into. But for example, we can see from lab tests that a patient has rising A1C values. And so when we start to see that, we can send information to the doctor to say that we're seeing either the patient that had a previous A1C value of 7 is now at 9, is at 11. And so that gives the doctor or the hospital a heads up that they're starting to see some declining clinical outcomes with patients. And so that's one of the things that we're really focused on in using our alerting product, is to start to be able to push out alerts when we're seeing data coming across that indicates that we're starting to see concerns with patients. We also have some analysis where we look at high-risk patients to be able to identify those that we believe, based upon the CMS guidelines, are going to, if they're not already the most costly, they're going to be the most costly patients. And we talk with our customers every year about what are the variables that they want included in that analysis? Because one of the things that, most high-risk patient analysis are based on claims data. And now that we have the opportunity to include the real-time clinical data, what we're finding is that those old algorithms based upon claims data don't really work any longer in the same way that you can use the real-time clinical data. And so we're starting to see a lot of innovation around the development of new algorithms using real-time clinical data and actually event notifications, not just that the patient's been admitted into the hospital, but an event like, the patient's lab tests have come back and there's, cause for concern, and the primary care doctors notified of that information, even if the lab was done, say, at a hospital or at a specialty care doctor's office. So I would say we're beginning to move in the direction of doing more predictive analysis with the clinical data. We're always interested in exploring more, though. So, if you have ideas, send them my way.
Great. And before we end our webinar, we would like to draw the name for our raffle, either a $100 Amazon gift card or a donation to Direct Relief in your name. Our winner today is Suzanne Rogers. Congratulations, Suzanne. I will be in touch after the webinar. And thank you all so much for joining us on today's webinar. We do have a quick 2-question survey that will launch in your browser at the end. We would appreciate you taking a moment to fill that out. Thank you and enjoy the rest of your day.